The PPCL tele-echo. This is the perinatal mental health tele-echo. I'm glad to see everyone today and hope you enjoyed. Hopefully you got a 3-day weekend, and I know today might be a little rough, but I'm glad you're all here. My name is Jody West, and I am the coordinator of this echo, and this is our 4th session. And I want to go over a few housekeeping items before we begin. If you could put your name in the chat, that has your information. That way we can make sure we get the slides out to you and the CEU survey at the end. This is our agenda. We're going to do our best to stick to this schedule. It's pretty tight, but we've done this before and we can move forward, and we will always stay on after to cover any questions that may need to be addressed, or we can do by email. I, again, am the coordinator. Dr. Olivier is our facilitator, and she is going to lead us through introductions in a moment. And whenever she finishes those introductions, Dr. Kara Brown is going to present on birth trauma and PTSD. Then we're going to have our case presentation. Margaret Smith was supposed to be our presenter, but she is ill today and gave us permission to go ahead and present her case. And we'll make sure to get the recommendations to her following the session. So then we're going to move forward with the rest of this agenda, and we'll wrap up at the end with announcements for the next time. I'm going to go ahead and introduce myself again real fast. Jody West, I'm the coordinator of the ECHO, and I am the program manager for the provider-to-provider consultation line. That is the program that hosts this ECHO. We provide no-cost statewide provider-to-provider telephone consultation or email consultation, as well as trainings, which is what this ECHO is, focused on pediatric and perinatal mental health. You can give us a call at this number, or you can also email us. We have online consult request form on our website, and we can get back to you, either a licensed mental health professional, or we can connect you to psychiatry if it's a medication or diagnosis question. But we'll put our, if you scan this QR code, it'll bring you to our registration, and we'll put our web page address in the chat. Dr. Olivier?
Hey, good morning, afternoon, everybody. I always make that mistake. I'm Dr. Olivier. I'm a psychiatrist here in Lafayette, Louisiana. I work in private practice at Bloom Mental Wellness, and I am the facilitator for these ECHO sessions. So I'm the one who tries to kind of keep us on the schedule. I'm going to keep introducing the hub team to you guys, and just welcome everybody. I saw some familiar faces, so thank you for coming back. And I also saw some new names, so thank y'all for joining us if you're joining us the first time. You already met Jody, who is our program coordinator. I'm going to ask Dr. Finelli to introduce herself.
Thanks, Dr. Olivier. Hi, I'm Juliana Finelli. I'm a child psychiatrist and general psychiatrist. I'm at Tulane in New Orleans. And I get to work with the PPCL team as a perinatal psychiatry consultant. So, and I'm a member of the hub team. Good to see everyone.
Thank you. How about Dr. Zena?
Good afternoon, everybody. I'm Paula Zena. I am a pediatric nurse and also a pediatric psychologist. I am serving on the team as a nursing consultant, and I'm happy to be part of this very fun and interesting group.
Thank you, Dr. Zena. And how about Katie Hebert?
Hey, everybody. I'm Katie Hebert. I'm a perinatal therapist, and I work in private practice doing counseling at Bloom Mental Wellness. Thanks for having me.
Thanks, Katie. All right, y'all. And so that is your hub team, and we're going to go straight from here into our didactic presented from Dr. Brown today. Thank you for presenting today, Dr. Brown. And the next 20 minutes are yours.
Excellent. Thank you for that introduction. And I'll be talking about birth trauma and PTSD today. Next slide, please. And just so everybody is aware, there are no disclosures for this talk. The slides do contain quotes from patients, and I just wanted to make it explicit that their permission and consent was given for quotes to be taken for the purposes of this talk. This is an abbreviated version of another talk, a longer talk I give, so we've got an ambitious timeline, so I may not review every single thing in every single slide, but the slides are going to be made available for everybody so that they can have those fleshed out details available if they're interested. Next slide. All right, so when thinking about birth trauma, literature is divided into two categories. First is going to be women who view the childbirth experience itself as traumatic, and women or birthing individuals who have prior trauma histories who then become re-traumatized during childbirth, which serves as the trigger. There's a decent amount of overlap between the two, but for the purposes of this talk, we're going to focus on the former definition. Next slide. Next slide. Thank you. And so if we look to actually define traumatic birth, for years, the literature focused mostly from the obstetrical perspective and less on the psychological perspective. So you see studies that focused on uro-gyn complications associated with delivery. There was no real conventional definition for the psychological traumatic birth until 2004. Cheryl Beck defined it as an event occurring during labor and delivery that involves actual or threatened serious injury or death to the mother or her infant. Later on, that was expanded. The birthing mother also is going to experience intense fear, helplessness, loss of control, and horror. Later on, expanded to include events in which the birthing mother perceives she is being stripped of her dignity. Next slide. The literature would suggest that 3 different components go into birth being perceived as traumatic. One is going to be the patient's perception, one is going to be obstetrical risk factors, and then the third is going to be patient risk factors. Next slide. Starting with patient risk factors for perception of birth being traumatic, age lower than 18, first-time mothers or first-time new parents, belonging to a lower socioeconomic status, being a member of a BIPOC community, having a prior trauma history, prior psych history, substance use, insufficient prenatal care. Next slide. Obstetrical risk factors. Over and over, we see in the literature that C-section, especially urgent or emergent C-section, and instrument-assisted delivery, so use of forceps or vacuums, are going to be implicated in patients perceiving their births as being traumatic. Other things to consider: induction of labor, having a postpartum hemorrhage, having pelvic floor trauma, an episiotomy, or having medical complications arising with the newborn. Next slide. Most importantly, patient perception is going to be key. So despite what happens in birth, if a patient isn't considered, if they don't consider their birth traumatic, then the birth by definition isn't traumatic. And so sometimes I think as providers, we can forget that. Things that can contribute to a patient perceiving their birth as traumatic: having lack of information or perceived lack of information from their medical providers, so inadequate consent, lack of perceived empathy from medical providers, feeling limited or no support from their partners available, not feeling like they're being consulted about medical interventions, things that are being done to their bodies real time, and then inadequate pain control. A common theme that kind of emerges with the literature too is that there can be a mismatch between expectations and actuality of the birthing experience, and that's going to contribute to the birth as traumatic. So a patient that comes in for labor and delivery and they're intending on having a vaginal delivery without medications, and they have an extensive list of sort of goals, and they come out with a C-section for failure to progress, is going to be at a high likelihood of perceiving their birth being traumatic, even though to the providers, everything might have seemed to have gone smoothly overall. Next slide. So shifting gears a little bit and thinking about some of the impacts of birth trauma. We know that birth trauma is associated with delayed lactogenesis and lower rates of successful breastfeeding and chest feeding in parents. Longer duration of labor and having that emergent C-section are going to be really powerful predictors of having that delayed lactogenesis. And here I'm including a proposed mechanism by Dewey et al. Next slide. Psychologically, it's important to realize that for a lot of patients, breastfeeding can be a trigger on top of having a traumatic birth experience. Patients will describe having flashbacks to their delivery when trying to nurse. They will report dissociation during nursing. And a lot of times this can lead to some deciding to cease breastfeeding altogether. Where this is important is that staff efforts and well-intentioned efforts to try and assist patients with feeding can actually be re-traumatizing. So you'll want to proceed with caution. Next slide. On the other hand, it's important to realize that for some patients, breastfeeding can be pretty corrective, right? And so in these patients, you'll see themes of regaining control or mastery over the body. Soothing is used frequently in the narratives as well. And so we can't assume that everybody is going to fit. One size does not fit all. And it's important to ask and be open to feedback from patients to kind of figure out where they may fall on the spectrum. Next slide. We know that birth trauma has an impact on subsequent pregnancies. Traumatic birth makes sense. You'd have a fear of having subsequent pregnancies, especially first-time mothers. The literature shows that first-time mothers are going to be more likely to avoid subsequent pregnancies if they've had birth trauma involved in their first delivery. What that can look like clinically is requests for sterilization or even terminations of subsequent pregnancies. For patients that have had recurrent pregnancies and do go on to have another pregnancy, you can see higher rates of requests for elective C-sections, element of trying to regain control over the situation, over a subsequent pregnancy, and longer pregnancy intervals. So going for a longer period than initially planned between. Next slide. So birth trauma is associated with a lot of psychopathology, postpartum depression, postpartum anxiety, disordered eating, but PTSD, postpartum PTSD is probably the best studied of the illnesses resulting from birth trauma. A lot of the literature that we have is qualitative or epidemiological studies that are looking at retrospective data, but what we can estimate is that the prevalence in the US is about 2 to 8%. Next slide. And so here's our DSM-5 criteria for PTSD. Wouldn't be any type of mental health talk if we didn't have a DSM-5 slide. But you can see that in order to meet criteria for PTSD, there has to be an exposure. There has to be the presence of intrusion symptoms, cognitive symptoms, hyperarousal symptoms, and avoidance symptoms. And they have to last for at least 1 month following the trauma. Otherwise, acute stress disorder is met. And this disturbance must cause significant symptoms, significant distress or impairment. Next slide. So what does this look like clinically in the perinatal population? So for intrusion symptoms, patients will describe flashbacks and nightmares of their deliveries. They will think about almost as if they're on autopilot, thoughts of how ill they were or how near death their infant was. And they'll report some of the dissociation while breastfeeding, potentially during intercourse as well. Next slide. Avoidance symptoms in the postpartum can also be pretty striking. Patients may delay naming their infant. They may refuse to see the infant in the nursery or NICU. These may be parents that decide that they don't want to room in, ask the child to be taken away to the nursery. There may be a reluctance to be discharged. They may avoid talking about their pregnancy or delivery. They may avoid reading about birth or pregnancy-related topics. They may struggle to resume sexual intimacy. Clinically, they may not make it for their 6-week postpartum check. They may have difficulty taking baby to the pediatrician. And as we discussed earlier, they may avoid subsequent pregnancies altogether. Next slide. Cognitive and mood symptoms in the postpartum can be a little bit more challenging to pick up. And there is, of course, some overlap with postpartum depression here. Specifically for birth trauma and postpartum PTSD, the literature describes impaired mother-infant interactions. Parents blaming the infant for the birth experience themselves, numbing and difficulty attaching to the newborn, and having even an inability to recognize the infant. A lot of times you can imagine how having such impaired interactions is going to drive substantial guilt. Parents know that to feel such things or to have such thoughts are not common and are not likely to be perceived well by society, by other providers, by other parents. And so they will not necessarily bring this information forward unless they're asked, and they might describe substantial guilt around having these thoughts and these feelings. Patients will also describe an increased desire to kind of make sense of or understand the delivery. They may want to go back to it over and over and over and over again. And irritability and angry outbursts can be common, sometimes directed at healthcare providers. Again, important when you're thinking about those early postpartum days while a patient still may be in the hospital. If they've had a difficult birth, if they're beginning to have symptoms emerging, that can look like threats and anger towards the healthcare team that's assisting. Next slide. All right, so when you're thinking about making the diagnosis, you got to ask, right? So assessing for symptoms can be really challenging for providers sometimes because it means having a difficult conversation. It means sitting with something that is awful and terrifying, and for some patients, some of the worst moments of their lives, being able to contain that. If you don't ask, though, you're not going to be able to make the diagnosis. And so certainly some patients will be given a PCL5, which focuses on sort of the traditional symptoms of PTSD. The City Birth Trauma Scale is a newer study that's been validated, 29 questions, free, easily downloadable, a bunch of languages it's been translated into. There's a version available even for birth partners that takes the PCL5 and sort of makes it more applicable for the actual event of birth trauma. And this can be a useful tool, especially if you don't have the time necessarily to have a detailed conversation where you're asking the questions, but you still want to make sure that you're obtaining enough evidence and information from the patient. And it's an easy enough scale to be administered in the office or prior to a visit, and can help you make the diagnosis. Next slide. So what to do when you have these patients come through? A lot of times they're going to need extra support, right? In terms of psychotherapy, the strongest evidence available is for trauma-focused therapies. Makes sense. However, the literature is going to suggest that it's helpful for treating PTSD, not really great evidence in supporting prevention of PTSD. So back in the day, about 2 decades ago, psychological debriefings were really, really common, especially overseas in Australia and Britain. And it was thought that if patients could receive support while they were still in the hospital, it would prevent them from going on to developing postpartum PTSD and other illnesses. Patients loved this. The literature did not support that it actually did anything meaningful to prevent progression to the illness itself. However, therapy can still be really, really helpful for prevention or for treatment, of PTSD and other related illnesses. And there are some specific techniques that can be helpful, even if you're not doing a trauma-focused therapy. Exposure work can sometimes include having the patient write out their birth narrative or even recount it in the controlled setting of a session. Sometimes bringing in partners and other family members to provide psychoeducation can be really, really helpful. Mindfulness work can be really helpful. Progressive muscle relaxation, safe-guided imagery can be really helpful. All these things can be used even, again, if you're not doing EMDR or some specific trauma-focused therapy to help provide relief. Next slide. And then in terms of medications, you're going to treat this similarly to sort of standard PTSD, with SSRIs and SNRIs being the first line medication choices. Sometimes, depending on symptoms and other medical factors, you may want to consider sedating tricyclic, mirtazapine, prazosin, or clonidine for nightmares or hypervigilance. Typical antipsychotics can sometimes be used as well. You'll really want to be mindful of the lactation data and the patient's goals around breast or chest feeding. A lot of people love to use benzos, especially in the immediate postpartum. It can be helpful for sleep, helpful for that high anxiety, but the literature continues to remain sort of not great around benzo use following trauma. It can sometimes harm consolidation of memories that are really important to sort of processing the trauma in those early stages. So you just want to be really, really mindful, especially if a patient is hospitalized, they're going home, you're going to send them out on something to sleep. You may not want to send them out with a script for a benzo or a hypnotic like Ambien. Similarly, literature isn't great with sort of treatment of symptoms with trazodone, Topamax. These get used sort of commonly or proposed, but the literature just hasn't borne them out. So most likely you're looking at SSRIs, maybe Effexor. Next slide. I think that's it. Yes. And I'm at 12:20. Did it.
Great job, Dr. Brown. We have a few minutes for questions, so
Yeah.
we can open it up to the floor.
That was a whirlwind. I'm sorry I had to go so quickly, but yay.
Anyone have any questions?
Looks like Angel raised her hand. Angel, you want to come off mute and ask your question?
Thank you. So in my previous role, I was a neonatal intensive care unit nurse. And so I did see a lot of moms with PTSD, and other like postpartum depression issues really related to kind of what you were talking about on your first slide, where there's this like perceived way, like they have a birth plan, they have this perceived, in their head how their birth is going to go. And then things take a turn for the worse, and then it kind of just sends them in a downward spiral. And so I was just wondering, is there any like literature, any thought to like preparing these moms beforehand that like we can make all the birth plans we want, but nature is going to do its thing and it will not always go as you plan, to kind of like talking about that prevention aspect of it? Oh, I think you're on mute.
Sorry about that. I think you said it perfectly. As best you can have conversations up front about potential complications that can arise. Patients will both feel like they have all the risks. They'll feel that, like, again, that idea of informed consent, like they know and fully understand what they're going into and the potentials for complications, but then simultaneously like reassuring them that they will be under good care. I think sometimes people worry that by acknowledging potential complications, it may enhance fear and avoid doing it altogether. But I think when you're able to have that conversation in a skillful manner, patients actually feel a little bit more reassured. They're made to be aware, and certainly can sometimes reduce that risk of, okay, well, I know this happened, but at least we had talked about it beforehand. Again, that idea of surprise may be diminished a little bit, even if it can't be fully reduced.
All right, thank you so much, Dr. Brown. We're gonna roll into our case presentation at this time. I did have a question in the chat about getting the slides, and those will be emailed to everybody at the end of the session. Also, the CEU link will be emailed with that.
All right, well, everyone, well, thank you so much for attending today. Please make sure you put your email if you haven't in the chat, and we're going to drop the survey link into the chat. But like Dr. Olivier said, we'll send out recommendations. And I'm sorry I have my camera off, but I went purple apparently, so I don't know. I'm just going to leave my camera off. But we'll send recommendations, the slides, and the CEU link by tomorrow to everyone that participated. And so then our next session is going to be on Tuesday, June 25th. And Dr. Zena is going to present about the benefits of infant massage on the parent-child dyad. So we're really excited about that. Thank you for spending your lunch break with us. And we'll stay on if anybody has any additional questions, but we look forward to seeing everybody next month. So thank you and have a good rest of your day.